get into some ergonomics and neurosurgery and some tips for a long career. We'll start with a case presentation, go through some history, the significance of all this, and research.
How long is your career?
It's on the fritz, honestly. So we'll start with the case. 32-year-old neurosurgery resident, years of neck pain exacerbated when he wore loops and a headlight. When he was under the microscope with someone not as tall, he treated with ibuprofen and neglect like a good resident. One day he woke up with severe neck pain radiating on his arm, left triceps weakness. You can see some loss of cervical lordosis here on the x-ray and a herniation at C6-7. So the resident thought to himself, how did my life come to this? What could I have done differently? How am I going to have a long career in neurosurgery at this rate? We'll get back to him, but he should learn about the essential topic about ergonomics. Put simply, this is how workers interact with their environment and how interaction influences task-related performance. Greek origin from ergo meaning work, nomos meaning natural law or custom. Dates back to 400 BC where the Greeks, you see drawings of chairs with contoured backrests and hand tools that they use similar to today. 1867, meat assembly lines in Chicago for the first time where they use a pulley system to bring meat to each worker. Then in the 1900s and World War I and II, they realized that the design of military planes and equipment was kind of essential for functionality and the success of completing their tasks. Then computers became more mainstream in the 80s, and research kind of blossomed with this. And they were looking at ergonomics of the distance you sit from the computer and your posture while typing. And then that kind of brings us to the explosion of ergonomics in surgery and ultimately the formation of this surgical group. So Dallas, why should I care about this and why do you care about this? I used to race motocross and do those big jumps, and as you would expect, this obviously led to injury multiple times, whether that be 2 broken legs in a wheelchair, thrombus, where I need a thrombectomy for thoracic outlet, open surgery. These are actually pictures from my surgery where they had to clean off my plexus and do a subclavian patch, first rib resection, and more recently, as we all know, my shoulder surgery from softball. So, why do I care about this? Neurosurgery is a battle, and you put your body on the line in the OR, and I worry about a long career, like Dr. Blackburn was saying. And so to maximize longevity, we got to figure out how to do that. So ultimately, surgery is a contact sport. It's been stated repeatedly. And so we really have to treat our bodies like athletes to maximize, maximize our ability. We have to look at every tweak and twinge, and this really comes down to the essence of what ergonomics is at its core. We can break this down to 3 general categories: our body position while operating, with the goal of being near neutral, the equipment we use to limit physical stress, and the preparation and recovery we give our bodies outside of the OR. We'll skip through the anatomy just due to time, actually, but important cervical spine stability. You really need your parascapular muscles and these deep neck flexors. In this article from HSS, described the forces on the cervical spine with our head at various degrees. It was geared towards text neck, but it's pretty similar to our position that we do in the OR. You can see that as you progressively increase the degree of flexion, that weight increases. And so it's pretty easy to see how chronic neck flexion over time can cause issues for surgeons. This is a very familiar picture to all of us in the OR. In a similar study, for every 1 inch of forward head posture that was found, an increase of 10 pounds was found on the spine. So in this study, they looked at 60 spine cases and found an average of 5 inches, which is averaging 50 pounds of extra weight on your cervical spine. And additionally, we use these adjunctive equipment, which is associated with longer periods and unfavorable positions. Loops are associated with 85% of procedure time compared to without loops, and headlamps similarly almost 80%. So these are things we do in cases every day. And it puts us at risk for developing these work-related musculoskeletal disorders. And these are just other risk factors, using Kerrisons with repetitive hand movements, lead aprons, our plus-size patients that we lift. And so these work-related musculoskeletal disorders, how common is it in surgeons? In this big study by FCN in 2019, looked at over 5,000 surgeons and the prevalence. You can see very high rates of neck, shoulder, back, and upper extremity pain. And 12% of surgeons actually in their study required some leave of absence, restriction in their practice, and early retirement as a result. And when looking at the national health data on work-related musculoskeletal disorders resulting in days away from work, it actually shows that these numbers are higher than labor-intensive jobs like construction workers, agriculture, and mining. You know, I know you're thinking, I'm not just any surgeon, I'm a neurosurgeon, and those other surgeons are wimps. You know, that comes out in a Dr. Day voice in my head. Different and capable of handling these stresses that others wouldn't endure. You know, we may not be as strong as we think. So I think we'll look at some subspecialty specific data. When looking at spine surgery, this 2022 survey of 180 spine surgeons showed a 1 month prevalence of neck pain would be 74%. And that's compared to 23% of the general population. Another survey of Scoliosis Research Society members that all do big whacks every day, you know, showed the prevalence of these disorders pretty striking. 100 times the rate of cervical disc herniation, 5 times the rate of rotator cuff pathology, 10 times lateral epicondylitis, 10 times lumbar disc herniation. And when looking at the rates of surgery, you can see a huge difference compared to the general population. 10% versus 0.3% cervical disc disease, 23% versus 5% in lumbar discs. And, you know, maybe a little biased because spine surgeons probably are more likely to seek intervention, but those are still pretty big numbers. And 32% required time off. We all like to think that spine surgery is, you know, worse on the body than cranial surgery. Not a lot of studies really support that. And this big European survey where they looked at pure cranial versus pure spine surgery, they didn't find any difference in these work-related musculoskeletal conditions. This CNS survey reported ETBs actually to be the highest rate of musculoskeletal complaints. So be careful, Dr. Eskenazi. It's dangerous out there. And then when all the factors that they looked at, like the average duration of the procedure, hours per week in the OR, all these things weren't significant, just tenure less than 15 years. So as you would expect, not, you know, younger people. In endoscopic and skull-based surgery, very similar numbers. And the interesting about all these is that when you compare them to the rates of professional athletes, like football players, the prevalence is pretty similar. 42% in professional athletes for football compared to, like, you know, 45 in endoscopic and skull-based surgery. So it kind of leads us back to the idea that surgery is a contact sport. And just as athletes pay attention to the needs and demands of their own bodies, we want to be able to do the same so we can enhance our longevity and our excellence. So what do we do about it? I split them up into 3 main categories: what we can do from an institutional standpoint, technology that we can use, what we can do ourselves. So institutionally, what can we all do together? You know, education is pretty much non-existent. You kind of just learn over time and learn what works for you. So hopefully this grand rounds can serve as some type of education. But, you know, that we could see that there's pretty stark differences in attendings versus trainees, particularly in cranial. You can see that when looking at the amount of forward head flexion in cranial on the right side here, I don't think my mouse is showing, but significantly more time in flexed head posture, 18% versus 3%. And this is just another, just saying, cranial attendings, more shoulder pain than spine. Very interesting. And we don't have many educational resources in neurosurgery, but the American College of Surgeons recently published recommendations on OR setups and stretches before and after operating. So I wanted to highlight a couple that they recommend important for us. The first is monitor height, which is useful in transsphenoidal surgery and ETBs. They recommend the positioning of the top edge to be at eye level so that the center of the monitor is slightly below eye level, which allows you to have a neutral neck. In open surgery, they recommend having the table height at elbow height so that your hands are closest to 90-degree angle with your elbows. Your wrists are straight and your arms aren't crossing midline. You really want to operate in that box. While we're on the topic of the positioning of your arms, I want to also comment on arm and hand positioning in microsurgery. It's really essential to brace your arm or hand. This study looked at 4 different conditions compared to just having a free floating arm, which is what a lot of residents do. And you can see there's a significant reduction in tremor. So either using the arm, hand, helps with tremor and also reduces fatigue in the arms and shoulders in these long cases. Back to the ACS recommendations, they do recommend micro breaks every 30 minutes or so. This is like a 1 to 2 minute break where you do posture stretches and exercises. And yeah, I realized that in the middle of dissecting out a ruptured aneurysm or an emergent hemicrania where someone's herniating, it's probably not good to do it during that. But there's a lot of times that we kind of sit around and we could incorporate this there. In this study, they looked at various specialties, including neurosurgery, with control days versus intervention days. And on micro break days, there was significant improvement in shoulder pain. Most people either had improved or no change in mental focus and physical performance. Very few actually diminished. And there's no differences actually in surgery duration. This is another looking at shorter breaks, 20-second breaks, and they were performing simulations, again, with neurosurgeons as well. They found a 7-fold reduction in these errors. So what can we do during these breaks? Some cervical range of motion exercises to help with stiffness, just slowly move in each direction 10 times. And these next 2 are for neck and shoulder stabilization. The first works on your deep neck flexors. You want to imagine you're trying to make a double chin, gently tuck your chin back and retract your head backwards. It's a small movement. You really want to try not to activate your sternocleidomastoids. And then scapular retraction helps open your chest, squeeze your shoulder blades to the bottom down there. These are some hand and arm ones that you could do in the OR. I want to go over the first one specifically. The lumbar fold muscles in the palm are responsible for fine motor control, precision grip, and strengthening these can help improve these functions. So you hold each for 10 seconds and then return to this neutral position Z, and then move to the next one. In this trial where they looked at 141 surgeons they tried to implement a preventative program where they incorporated ergonomic principles and a 6-month program where they did pre-op and post-op exercises. And they found significant reductions in back pain and use of analgesics. Interesting. So it seems clear we should incorporate it into our department at institutional level. Technology, there's a lot of different technologies, which we'll go through some of the things on the other side of the spectrum, but loops and microscope, things we use to visualize. This looked at the angles of 12 spine surgeons performing discectomy, and they use these surface markers to look at posture. Pretty interesting when looking at how far flexed you are when doing the ipsilateral side, midline, and contralateral. And they found that the microscope was best when trying to get the natural posture, followed by naked eye and loops. And the optimal table height with all their tests was between the umbilicus and the sternum. They also have a nice picture up top. There's angled loops that they make now and help reducing the forward flex posture. So it's just something to consider if you're in the market for new loops. Exoscope's another technology, and the benefit of this is you position it over the open surgical field. Your eyes are on the monitor, and that's one of the proposed benefits. It's more ergonomic, and studies have shown improved neck and back pain with the exoscope compared to the microscope or loops, which you can see down here. It's been used across the full spectrum of surgery. I don't know why my slides are getting cut off, but whatever. Tumors, MI, spine, skull-based techniques. This is showing an improved comfort score. And you can kind of see that the posture when using the exoscope here, straighter back compared to like the flexed, hunched over posture on the far right. Another example of using technology to help yourself would be, using power and screw placement in spine surgery. This compared traditional manual techniques with the use of power-assisted tools. And they put EMG recorders on different muscles to record over the duration of a procedure. And they found huge improvements in every muscle tested with about an 80% reduction average of muscle exertion, which you can see on the bottom chart here. And they additionally found that using the manual technique put surgeons at risk in their neck and upper extremities, very high levels of exertion for up to 92% of the procedure. So that kind of highlights use, overuse injury that you can have. So what can you do? Most importantly, on your day-to-day lives to reduce work-related pain, focus on good posture. You don't want to look like this person on the right. This looks terrible. You want your eyes aligned over your shoulders, your ears over your shoulders, chin parallel to the floor, shoulders even, cores braced, hips neutral, knees even, pointing straight, and your body evenly distributed on both feet. Outside the OR, invest in your physical fitness. This can translate to strength and endurance in the OR, whether it's yoga, Pilates, strength training, cardio, whatever works best for you. This is just a quick article. Some other stretches that I think that are important that you could do just in between cases, just grabbing on whatever you can find, decompress your spine, pull back, cat cow, if you can just find an empty pre-op room, go on one of those beds. Doorway stretch, the upper trapezius stretch. We already went over this neck retraction one, but very important, especially for us that are doing forward flexion for long cases. And then scapular retraction, really focus on squeezing the scapula in the back. And then these are just lower back and core exercises as well. And this is, they even have an animation of a guy wearing scrubs doing these, so you guys can do it too. Now back to that resident at the start of the presentation. This is a made-up person. I don't want to put anyone in the line of fire, so I won't use anyone's name. We could call him person X. Ideally, he would have focused on maintaining a good posture, whether that be with another surgeon that's similar height. Or even you could stack two people on top of each other. Keeps him in a neutral position. And if you have either of these, you get the green light from the boss to go do the next part of the case. But unfortunately, in reality, we're not always focusing on these things. And so person X bit the bullet because he's tough and he operated, ended up having significant forward flexion. This looks like a forward head posture about 20 inches, which is like 200 pounds of extra weight, really tough. Over time, this can lead to significant neck pain, but it's still time to turn around all of these principles. So that he's not on the road to disability. We don't want that. So in summary, ergonomics matters. Work-related musculoskeletal disorders are high in neurosurgery. So take the extra time to ensure you have the proper OR set up, implement micro breaks. They don't prolong the case, use technology, exercise, and just be aware of your posture because these small changes can make a big difference in the long run. And thanks. This is a picture of my dad, actually. He was a bodybuilder and kind of, implemented the importance of the gym early in my life. And this is my new study partner for research and my NAP partner. And he actually is working on his ergonomics down there with his new rattle, which is a weight. So yeah, thank you.